Hello, my name is Liz Heileman from HIVandHepatitis.com, and we're here at the Conference on Retroviruses and Opportunistic Infections in Boston to talk about hepatitis C today. I have with me Jürgen Rockstroh from the University of Bonn in Germany,
Hello.
Kenneth Sherman from the University of Cincinnati, and Dost Sarpel for the Icahn School of Medicine at Mount Sinai. So first, why don't we have each of you in turn talk a little bit about the research you're presenting or your group is presenting at the conference. Do you want to start?
Sure, let me kick off. So we're presenting a study on the treatment of acute hepatitis C with a fixed-dose combination of litipiravir and sofosbuvir. So as you may know, there is no approved indication for the use of DAs in treatment of acute hepatitis C, so people who newly get infected with hepatitis C, and we consider up to 6 months as the phase where we define as acute, and then it becomes chronic.
I'll just say many of our audience may know litipiravir sofosbuvir as Harvoni is the brand name.
Yeah, it's the brand name. And so the question is, does that work in a shortened cycle of only 6 weeks of treatment? Referring to that in the old days, at least with PEG and RI, we were able to have shorter treatment durations in acute hepatitis C with high cure rates. And I think the interesting thing here is that every patient is cured except those who have a really high baseline viral load. So baseline viral load seems to determine whether you have a risk of relapse or not. Overall, it's a little bit over 80% who respond. There are 2 patients who are unfortunately lost to follow-up between SVR4 and 12. But overall, the 3 relapses are really those with a viral load above 7 log. So, and I think that could give us some, practical considerations in practice that we can use shorter treatment cycles in acute hepatitis C if we're sure the viral load is not that high.
Let me just ask as background, does hepatitis C work like HIV where there's a big viral load spike sort of soon after infection and then it goes down naturally?
Yeah, so basically during seroconversion, we actually do see a very high viral load. You're right, and I think that is maybe also in parallel to HIV. One of the reasons why we believe that a lot of the passing on of the infection is happening during that phase where there are particularly high viral loads. And then when the immune system kicks in and sort of arranges, then there's some people who even spontaneously clear infection, very different to HIV, where everyone goes on to develop chronic infection. That's in the setting of HIV, not very frequent, but 15% clear infection. And then depending on how your immune system sort of interacts with the virus, you have different levels of viremia.
Okay, great, thank you. Dr. Sherman?
So one of the emerging themes at this meeting is in the area of hepatic fibrosis. We've known for years that one of the dominant factors of causing fibrosis in HIV-infected persons is hepatitis C. But as we've developed in recent years better therapies for hep C, there is hidden underneath the damage from hep C a variety of other things that are causing liver injury. And we're beginning to see movement towards understanding better factors associated with the development of fibrosis other than just hepatitis C or hepatitis B, and efforts to think about how can we manage that, how can we treat that. So in that regard, my group has data that was presented yesterday that took samples from patients who were treated in a clinical trial with a drug called cenicriviroc. Cenicriviroc is a CCR5, CCR2 inhibitor. And in a trial, a phase 2 trial done a few years ago, the use of cenicriviroc with a Truvada backbone was associated with equal HIV suppression as in patients who were treated with a more standard efavirenz Truvada regimen. We took samples from that study 1 year baseline and 1 year later after treatment and began looking at fibrosis markers, in particular using something called the ELF index, which are individual biochemical markers directly of hepatic fibrosis or in one case, an enzyme that actually inhibits the resorption of scar, so more of it means more scar is there. And we compared the outcomes at baseline and 48 weeks down the road, and the patients who received a dose of 200 milligrams a day of cenicriviroc actually had significantly lower ELF scores than patients at the lower dose of cenicriviroc or those treated with efavirenz, suggesting that this agent may, by mechanisms that are still poorly understood, be inhibiting the development of hepatic fibrosis in patients that don't have Hep C or Hep B.
Excellent. Thank you. And Dost?
So our group, we're looking at ledipasvir, sofosbuvir failures that we've seen in our clinic. Multiple studies have been presented at the AASLD meeting in San Francisco last year, as well as other meetings, looking at factors that are associated with failure. And these factors that they've shown, male sex, African American race, cirrhosis, platelets less than 100,000, prescribing outside the FDA guidelines, and some suggestion of PPI use as well. These were seen in studies like TRIO and HCV Target. So we wanted to look at our patients that we've been treating with ledipasvir, sofosbuvir. So we had about 29 patients that failed ledipasvir, sofosbuvir. Some were co-infected. About 15% were co-infected with HIV. Most of them received 12 weeks of therapy. A couple had 8 weeks, and a couple had 24 weeks. And we just looked at some of these variables to see if any of them were statistically significant in our patients. And what we found was that African American race and male sex in our cohort was significant and associated with failure. Cirrhosis was not, at least in our cohort. Interestingly, so this was, in our clinic, this is real life scenario, and what we found was, a lot of these patients didn't exactly present at, SVR week 4 challenge or week 12. They tended to come in at different variables. So of the patients that failed, about 80% of them failed at their very first visit, whether that was week 4 or week 8. Everybody failed by post-treatment week 24. We didn't suspect reinfection in any of these patients. 80% of them had repeat genotypes done, and they were all the same genotype, and they all relapsed pretty quickly, and they didn't really have significant risk factors for reinfection, so we presumed it was all relapse. So it's sort of what we're seeing in the real world, and about half of them did get resistance testing, and we looked at the different resistance-associated variants that we saw in this cohort, and then about a quarter of them are currently undergoing retreatment. So we're following these patients and seeing what they got retreated with, and the others are being evaluated for retreatment but haven't started it yet, for various factors. But we will follow these patients and see what happens.
Thank you. And since you brought it up, that was another topic that's becoming more pressing as a lot of people are getting treated, and that is reinfection and how we might prevent that, I guess, especially in the context of people who inject drugs, perhaps, or people who, especially men who have sex with men who are having sexually transmitted or apparently sexually transmitted hepatitis C.
Yeah, I think last year's CROI was a really great analysis from Andrew Hill, looking at a meta-analysis of all kind of studies, looking at who is at risk of reinfection and how high are the rates. And it's interesting to see that if you got it through blood products, your risk is probably around 0 and hardly anyone gets reinfected. But if you have a hepatitis C through IV drug use, then you remain at risk if you in particularly become incarcerated again, go to prison, or don't have access to methadone substitution or clean needles. And I think that for me is the important message, is that we have the tools to prevent reinfection for IV drug users, which is very different to the reinfection rate in men who have sex with men with acute hepatitis C, where obviously behavioral changes are much more difficult to reach, and you can't just
But it
reach it
sounds
by
like
saying.
we don't exactly know the risk factors, so it's
Yeah,
even harder
and that's
to say what.
an ongoing area of research and discussion. How does that really happen? Is it really more traumatic sex practices with an increased risk of blood-blood contact? And what is really the underlying driver of this all? And obviously, if you can't exactly pinpoint what causes transmission, then it's also difficult to establish better prevention measures. But the reinfection rate in MSM with acute hepatitis C is 25% in the first 2 years. So that, I think, is a real issue, and it's something we really need to tackle.
Do you think it's fair to say that condoms could help prevent sexual transmission of hepatitis C?
Yeah, well, condoms have become really unpopular because of the, overall very rightful conception that if you're undetectable for HIV, you're no longer infectious with that. But I think what we're sort of missing a
Or
little
if you're
bit.
taking PrEP, you don't want to use a condom often.
Exactly. So, but obviously that does not protect you against syphilis and hepatitis C. And clearly, without any question, at least in Germany, the STDs are a complete and dramatic rise. And so I think we do have to talk again about the condom in a certain sense, because that could help at least for some of the blood-blood contacts. Using a condom would be a way to sort of lower that risk of transmission.
Certainly the cost of retreatment is something that is likely to drive some of the conversation about policies related to greater access going forward.
Right.
In my part of the country, there's still great reluctance to consider treatment in anyone that's been a recent injection drug user who does not have multiple clean urine tox screens because of fear of reinfection and paying for the cost. Not that we can't treat, but that the societal cost of that is quite high.
But I think, in all fairness, it's also that is the group which has a risk of transmitting it to somebody else. So I think in a certain public health idea, if we would be able to treat people who present with acute hepatitis C and prevent onward transmission, I think that could be a very likely a cost-effective approach.
We've seen in HIV that treatment is prevention is effective. So.
Absolutely. So I think we'd have to invest a little bit of energy in that idea as well.
Great.
I think it's also linkage to care and provider education, because you have a patient, you diagnose them with acute Hep C, maybe there's a lack of knowledge of what can be done for these patients as well to cure them and prevent infection of other individuals as well.
Great. And in our remaining time, I'd like each of you to sort of give an opinion about what's the hot new news in hepatitis C, either at the conference or in general.
Well, I think one of the areas is obviously around new drugs coming along. Although there was not too much new data from new drug trials, I think we all very well aware that a new drug combination of crisaborole and elbasvir has just been licensed, and then there was at least some PK interaction study with regard to the next more pangenotypic agent. Gilead is developing the combination of veldapasvir with sofosbuvir, and it was interesting because obviously there's some drugs which are more difficult to combine. You are on an HIV regimen with hepatitis C drugs, and it looks as if veldapasvir is quite good combinable with pretty much everything except efavirenz. So that, I think, was reassuring coming from this conference. And obviously the availability of a drug which also works in genotype 2 and 3 offers a ribavirin treatment option for genotype 2. It offers better coverage for the genotype 3. So I think that brings some hope for those people who feel they have genotypes which have been traditionally a little bit more complicated to treat. And then I think one big new thing for me at least is that it's the first time that in the label of a drug, the Merck compound, you do require...
That's the one that goes by Zepatir.
Yeah, the Zepatir, that you have to have a genotypic resistance test in patients who have a genotype 1A. So it's not for every genotype, but just for the 1A. And there was a session here looking at the role of resistance-associated variants. And I think there's still a lot to learn, but I think what is important is that if you fail on a regimen that contains an NS5A inhibitor, that you have a pretty high risk of resistance, and that resistance can affect other treatment choices. So I think at least in treatment failure, you also will need a resistance test. I don't think that we have great guidance of what to put together then, but I think we're just beginning to understand that resistance, just like in HIV, may play a role.
Okay, great, thank you.
I think that one of the big stories that's emerging is the increasing risk of hepatocellular carcinoma. We're curing lots of people now, and I think it's easy to forget that those who have advanced fibrosis and cirrhosis are at risk, remain at risk for developing liver cancer.
Even after they've been cured.
After they've been cured. And in fact, we've been quite surprised at the number of cases that we've been seeing 1 to 2 years following cure. Enough compared to what we had in the past that we have to start wondering, is there something that's occurring during the healing process of a cured liver that is actually accelerating the development of HCC? Or is it just that the entire cohort has been aging and is getting to that point that HCCs are more prevalent? But within our group, we've been referring 2 to 3 patients a week to our hepatobiliary and transplant group after cure, and these are in patients we've followed for years. Right. So I think there's a story remaining to be told there, and a message for the entire community that you still need to be able to stage your patients, and you still need to continue to follow those that you've cured.
Screen for liver
Screening
cancer.
for liver cancer, yes.
Finally, Dost.
I think retreatment of patients who have failed is emerging, and you know, they're looking at different studies combining different medications, like Vicura and Sovaldi was used in one study. The new medication that we were talking about before, sofosbuvir and valpattosvir, which will hopefully come out later this year. Maybe using that in patients that have failed other medications, particularly, you know, the NS5A medications, some of the older ones, and then the newer drugs that are on the horizon that are being developed, you know, triple combo drugs, maybe using that, or maybe a quadruple combo or something along those lines. And obviously resistance testing will play a role, as we mentioned earlier, in all these patients that have failed the medications that are currently in use right now. So even if you fail now, there's still hope, you know, for the future of these new medications and combination medications that you can still achieve cure.
Right, so it sounds like even though we have good treatments now, there's still plenty to be followed
Right.
in the field of hepatitis C.
Even though the SVR rates for a lot of these medications are high 90s, there's still that small cohort of patients that have failed that we're still struggling exactly the best way to treat these patients as well. So I think that's sort of the next step.
Great. Well, thank you all for joining us here and signing off from the Conference on Retroviruses and Opportunistic Infections in Boston.